Good morning, everyone. It's my privilege to share with you these updates on the role of prolotherapy and regenerative injection therapy. And first of all, I would like to congratulate Indonesian Neurological Association for inviting me to speak in their conference. And I would like to especially mention Dr. Desi for organizing this conference to give updates to our colleagues, especially in Indonesia. So the title of my talk is The Role of Prolotherapy and Regenerative Injection Therapy in MSK Pain Intervention and Evidence-Based Medicine and Preparation. So as usual, I would like to cite these beautiful texts. It's found in Isaiah 40, 30, and 31. It says, "Even the youth shall faint and be weary, and the young men shall utterly fall. But they that wait upon the Lord shall renew their strength. They shall mount with wings as eagles. They shall run and not be weary, and they shall walk and not faint."
Philippines, Middle East, or Asia.
Thing is, so this one actually we can.
And needles coming from distal.
Tendon moves together.
The tendons that is being stabilized by this pulley system. Now, the learning objectives of this talk includes, but not limited to, the understanding and mechanisms and principles of prolotherapy and regenerative injection therapy. Next is to evaluate evidence-based prolotherapy and regenerative injection treatment in musculoskeletal pain management. And number 3, to identify patient as to whether prolotherapy and RIT is indicated for their conditions. And of course, number 4, which is very important, is to develop skills among colleagues in preparation, administration, and follow-up of patients treated with prolotherapy and regenerative injection therapies. So here are my course outline, as you can see here. And then, of course, let me begin by sharing with you the chronic neuropathic pain definition, which is actually a lesion or disease of the somatosensory system. And according to the statistics, 11 to 19% of the general population suffers from chronic pain. And of this, 3 to 17% suffers from neuropathic pain. And among those suffering from chronic pain, 20 to 25% are associated with neuropathic pain syndromes. And as you can see, this type of problem are associated with the involvement of A beta, A delta, and C fibers. And since it's chronic, so these are patients who have been suffering pain for more than 3 months, and they are either classified as peripheral or central type of neuropathic pain. Now, here are the positive signs of neuropathic pain, but I would like to highlight among these is allodynia, because this is a very unique feature of neuropathic pain wherein what used to be just a usual sensory touch, tactile sensation is interpreted as pain. So we call that the allodynia. The rest, like pain, hyperalgesia, dysesthesia, paresthesia, are distorted pain sensations that accompanies neuropathic pain. Now, here is the diagnostic criteria for acute neuropathic pain. And of course, we have the core criteria, which is an unpleasant sensory or emotional experience with associated actual or potential tissue damage, or described in terms of such damage that we have already mentioned, which we say there is a lesion that accompanies such pain. It could, the pain could occur for 30 days or more with specific neurological injury, and it could be located neuroanatomically consistent with the distribution of dermatomes and to some extent the myotomes. And of course, the pattern of pain that we have mentioned earlier is found in this kind of pain. The common features the patient is complaining would be described as burning, shooting, pins and needles, tingling, dull, aching, throbbing, or pressure pain. And these are typically described as non-neuropathic pain. Modulating factors may include age. The older you are, the pain is more with those patients. Immune function are altered, presence of other diseases like multiple sclerosis, Parkinson's disease, or genetic polymorphisms or psychosocial factors. And of course, as a result of this, you also affect the functionality of the individuals, wherein it affects eventually the quality of life. And of course, other putative mechanisms would include peripheral and central sensitization. Now, there are tools for diagnosing neuropathic pain. This includes your LANS, your DN4, or the pain detect questionnaires. So as you can see from these different types of screening tools, that the signs and symptoms are similar. There could just be different description, but more or less, the sensation that is being described is common, and it has, in a sense, very much the same in terms of symptoms. So I would like you to go over this and just to see for yourself whether these types of pain are present in your patients. Now, between the peripheral and central neuropathic pain, you can see here different patterns. So let me say central neuropathic pain are pain which are characterized by lesion that affects the spinal cord or the brain, and that presents itself as pain in different areas of the body. It could be found in the arms, in the legs, in the face, or there could be some patterns, especially if it's a spinal cord injury, wherein depending on the lesions that are involved and the levels of spinal cord injury, anything that is lower than that would show some degree of pain. And of course, the central pain characterized in multiple sclerosis also has its own pattern, as you can see in the diagram here. Now, on the left side, we have the peripheral neuropathic pain, which are characterized by different nerve injuries outside the central nervous system. And so when those nerves are affected, you can see that their distribution will also be the one that would be shown to be affected. It could either be a post-amputation, trigeminal neuralgia, radiculopathy, painful polyneuropathy, or peripheral nerve injury pain, or post-herpetic neuralgia. So all of these are patterns of peripheral neuropathic pain. What is challenging, though, is that from the onset of pain to the diagnosis, the time it takes for someone to diagnose this definitely would take about close to 2 years. And that is why we see a lot of these patients on a late stage, because the diagnosis by itself is very challenging. And from the diagnosis to a referral to a pain center also will take a little, about 2 years as well. So the total number of time it takes for a patient complaining of pain to the time it referred to a pain center would be almost 4 years. And that is the reason why these patients may be taking so many drugs at this point, and yet their symptoms doesn't abate. No relief of pain at all, because so many different, probably physicians are seeing them with different specialties and seeing them from different perspectives. So drugs are given to them on a symptomatic basis, and thus their pain doesn't go away that well. So you can see the challenge that we are facing right here. Now, there are different mechanisms of neuropathic pain. As we have mentioned earlier, there could be a peripheral sensitization, there could be a central mechanism that are involved, and other things in between are your spinal activation of glial cell activation or supraspinal mechanism. So all of these are the different types of neuropathic pain. I will not go over this anymore, but just for you to see that there are different types of mechanisms involved in neuropathic pain. Now, in terms of diagnosis, this is a flow chart that tells you that when a patient comes to you with complaints of pain, now it is possible that you suspect that probably this could be a neuropathic pain. The reason we have to suspect is because of the time it takes from the time the patient complained for the first time until the diagnosis, which takes 2 years, and for referral to pain for another 2 years, so a total of 4 years. So here, if you have a patient with his neurological lesion of the disease with pain in neuroanatomical distribution, you could probably suspect for a possible neuropathic pain, or if this is not present, then it's unlikely to be a neuropathic pain. But somehow, if there are sensory signs in that same neuroanatomical distribution, then that could be a probable neuropathic pain. And then you can do some diagnostic testing, as we have mentioned earlier. We have shown you, and then we can go and say, oh, we're dealing with a confirmed neuropathic pain patients. So this, I think, will guide you in the process of seeing your patient. Now, there are different ways to see this lesion, and the most common and the most plausible, I would say, would be to see the nerves to be innervated by its own nerve endings. So it's called the nervi nervorum. So a nerve is innervated by its own nerve, called nervi nervorum, and any impingement or entrapment, or maybe a lesion, or any abnormality in the flow of the nutrients into the nerve will cause it to swell, but at the same time, one segment would be stretched in the process when this area is stretched or swollen. And so we call this as the site of pain, or chronic constriction injuries, or CCIs. So this area here is the one that is most painful, and that is why when we look at it that way, the nerve is involved, and that is why it is painful. Now, some call this the valley point, and the valley point are the areas by which the nerve is compressed, and that is why it is painful, and pressure becomes great in those areas, causing neuralgia. And depending on which part of the body is involved, then you can see all these findings in this area. Then, of course, we have biomarkers of neuropathic pain. The usual thing that we do is, of course, erythrocyte sedimentation rate or C-reactive protein, but there are other newer laboratory tests that you can do, like your tumor necrosis factor, or some would say even doing all the pro-inflammatory cytokines at your leukin 1 and 6. You can actually evaluate them, and they will give you a result. And usually, if this is increased, this is what happens. It only validates the fact that you're dealing with a neuropathic pain. Or you can do also a SICAM, or soluble intercellular adhesion molecule 1, which is also a test that you can do. And these are all elevated when there are inflammatory processes affecting that area. Now, other tests that they can do is microRNAs. These are useful diagnostic and prognostic markers in the onset and progression of chronic pain. These are newer ones. We have MIR21, MIR146A, MIR155, and these are upregulated in polyneuropathies. But for painful neuropathies, it's the MIR, thus 21, which are elevated significantly, which means that the patient is indeed having some painful neuropathies. Other tests that you can do is your BDNF, NGF, and T3, and TRKA. So these are biomarkers that will point to you the presence of neuropathic pain. Now, in terms of the findings, of course, you can see here, if you dissect a tissue, you will notice that one area is swollen, one area is stretched, and one area is healthy. So the healthy ones are the ones which are well delineated. You can see that in the tissue, and it's also shown in the ultrasound. So it's consistent that this area is really normal. But then the swollen part, as you can see, it's diffuse, and you can see that there are no borders even in the ultrasound here. It's very much spread out, and it's the one that's actually causing the pain, and of course preventing it from preventing the nutrients from going into the area of diffusion. Then, of course, the stretch part would also show like this. And if you will notice, it's constricted, and that is the same way that you see also in the ultrasound. So it's very consistent, these findings with all of these anatomical abnormalities. Now, you can also see that in stains. If you try to stain the nerve that is affected, you will notice here the difference. The uninjured nerve will just look blue here, but a neuroma would appear green and blue with the background here. And of course, you can also do the H&E test, which is the more common test pathologically, and you can also see some findings there. There's an increased uptake of that color in the tissue, and if you go very closely, you can see all the chromatin materials clump up in this area here as compared to the one that is uninjured. Same also with S1R, where the materials, the protein, the chromatin materials are clumped, and this one is nothing. So it's normal. So the same holds true with the immunofluorescence staining. The uninjured nerve will look with the striations very nicely, but this one are clumps, and they are found in groups, and that is why they are very swollen. In the ultrasound, the same holds true. We use a power Doppler here, and you can see that there's a lot of neovascularization in the nerve tissue, both in short axis and of course in the long axis. So there's an uptake. That means there is an increased inflammatory response in the tissue when you put it on a Doppler, in the power Doppler. Now, what are the cellular and physiologic basis for these problems? Now, when we look at it in the perspective of channels and those receptors, what they found out is that there are complex ion channels in the nociceptor membranes that actually controls the entry of sodium, potassium, and calcium channels. And these are, I would say, voltage-gated channels, and it's an active process, so it requires glucose in transporting the substance in and out of the cell. But these TRPV1 receptors are the ones that used to be alluded to as that area that actually receives the response, in which case it allows the ions or it doesn't allow the ions. So this receptor is very glucose dependent. If there is pain, for example, the TRPV1 receptor will block the entry of the ions, and then the blocking would actually cause the ions to be staying in one side, and then it will cause a lot of pain. But since it's an active response, it requires glucose. Towards the end, and I will show it to you later in the slide, there is glycopenia in that area where there is pain. Now, what they also discovered is there are epineural channels, and these epineural channels, as you can see, are channels by which all of these things are happening. So as you can see here, the channels allows the entry of the ions here. So they identify the structure to be very important. And here, it is observed in the median nerve with fascicles that are either allowing these ions to pass in or not. I'm sorry for my voice. Then, of course, what they found out also is that the glucose under normal circumstances is usually in this area. It's flat. And when there is pain, for example, the firing rate is increased to about 653% more. And that will make use, or should I say, spend all the glucose available. So in 10 minutes, there will be glycopenia. And the glycopenia will further compound the process, and the patient will feel pain. But the surprising thing that they observe here is that if you reintroduce glucose, it stops the small fibers from firing and reverse the process. So this is a very interesting finding. This research was done 1992, so it's way early in the discovery of this particular process. Then you can also see here the signals that they found out when there is a normal nerve compared with the nerve that is used up, and you refill it with another glucose. Then, of course, from a stage of glycopenia where the glucose is used up, then the pain is more felt, and eventually the pain will be gone when you reintroduce again the glucose in this area. Now, another thing that they also find out is that in neurogenic inflammation, where the nerves are involved, there is an overproduction of neuropeptides in the form of substance P and CGRP. Now we know that these particular neuropeptides are found also in the dorsal root ganglion, which is the one that mediates pain in those areas. And in fact, these are introduced by, later on I will explain to you that these substances are released by a trigger of the inflammatory process. Now, the calcitonin gene related to that, or CGRP, are the ones which actually also release the calcium. And that is why sometimes we find that there are calcium stored in the tendon when there is pain, and that is because of the CGRP. And we wonder why, how it came about, how it find its way into the tendon, this calcium, and that is because of the CGRP. Now here, what is being explained here is that when you actually put glucose into the area of the channel, it allows the entry of the ions. So there is a free flow of ions in and out of the cell. But the glucose, when it's depleted, then the TRPV1 will be activated. And then as a result of that, there will be a decrease in the pH. So there is acidosis, an increase in hydrogen. There will be increased heat. And of course, the sodium and calcium will go into the cell. And of course, it will affect the normal process of metabolism, especially the mitochondria. And this continues on and on until such time that this is reversed. So the problem is that the area that keeps on firing when it is entrapped is the lack actually of glucose in those areas which are affected. So here, as we mentioned earlier, the substance P, which are floating in this area, the synapse, okay, binds to the NK1 receptor, and then this NK1 receptor acts on the different enzymes, and this is the one that actually facilitates the release of those neurotransmitters that are responsible for pain. To some extent, they also release other things like reactive oxygen species that augment the M-type potassium channels, which are actually the one that may also influence the macrophages to increase its M1 type of macrophage. And I will tell you also that later on there are shifts of these different types of macrophage. So hypoglycemia more than hypoxia increases C fiber receptor firing and ischemia. So as you can see here, in the control, this is how it looks like. When there is hypoxia, this is how it looks like. And when there is L-glucose, as you can see here, there is a cumulative effect. And then, of course, when it is decreased, there will be a C fiber receptor firing. And that is the reason why patient also feels the ischemic pain on those areas that is affected. So hypoxia could produce a statistically significant increase in discharge frequency compared to control, but hypoglycemia produces a significant increase relative to both control and hypoxia. So when you have those two things together, there's hypoxia and hypoglycemia, it would not produce a significant greater increase in discharge frequency compared with hypoglycemia alone. So you can see here the difference. You combine the both, not significant, but the glucose is very significant as compared to hypoxia. So where are these C fibers? Where do you find them? You find them everywhere. So if you're talking about tendon, dermis, fascia, perimysium, periosteum, paratendon, synovium, all of this have their C fibers. So in other words, any of these areas, once there is an alteration of the mechanism that is involving the exchange of these ions with the TRPV1 receptors in the presence of C fibers, then this can cause pain at the same time. In fact, it could also go into the motor end plate as well. And that is why, to some extent, the patient cannot move, because secondarily, it could affect the motor end plate. So the areas involved is very, very much elaborate. The brain and nerves are high-frequency users. The TRPV1 here actively requires a lot of energy. So again, the source is glucose. So here, when there is a prolonged TRPV1 activity, it will lower the glucose as we have explained earlier. And of course, it will cause an acidic environment. The pH will go low, and then there will be a lot of inflammatory response. And C fibers will run out of energy, and the result is chronic pain. Now, other explanation, of course, is the role of peripheral central neuroinflammatory process in neuropathic pain. As you can see here, it's just an enhanced type of pain here, but I would like to highlight the presence of microglia. This microglia is activated once there is pain, and at the same time, when this is activated, it also will activate the astrocyte. The microglia here is the one responsible for releasing the macrophage, especially M1 macrophage. The M1 is the one that is more into the inflammatory type, in contrast to the M2, which is the one that is present in a healthy type of nerve. Now, in the peripheral as well, there will be a peripheral sensitization, and there will be a release of interleukin and TNF-alpha. These are your pro-inflammatory cytokines, even at the level of the dorsal root ganglion. Same holds true here with the nerve terminal. Okay, the glucose, the BDNF, substance P are the ones responsible in the energy production that actually is responsible for the transmission of impulses in this area. And if there is any alteration of that part, then of course there will be a release of microglia, which is responsible for M1, the release of pro-inflammatory cytokines. These are the pro-inflammatory interleukin 6, interleukin 1 beta, TNF alpha, and of course a delayed response for other cells would be the astrocyte. Astrocyte tends to persist even after the inflammatory process. So here, as you can see, the immune cells are activated, and as I've explained earlier, the pro-inflammatory macrophage is released within 24 hours. That's the M1. And then eventually after that, the astrocytes will persist for up to 12 weeks. So can you just imagine the amount of time that is affected when you have this inflammatory response? And the activated M1 will release the pro-inflammatory cytokines, which are what we have mentioned earlier, the interleukin 1 beta, interleukin 6, and TNF. And it will also be found in the dorsal root ganglion. And up to this point, these pro-inflammatory cytokines will further increase the neuropeptides. And those neuropeptides are the ones we have explained earlier, the substance P and the CGRP. So M1 versus M2. So thank you, Dr. Baumgartner, for sharing this to us last week. But this one, the M1 pro-inflammatory cytokines are, we have already mentioned it, and it will cause tissue damage and promotes central sensitization. It prolongs pain signals after injury. But the M2, which are the anti-inflammatory, it will release interleukin 10, TGF-beta. It will resolve inflammation pain with healing. It also supports cartilage repair and reduce pain. So this one, these two macrophages are released depending on the environment. So if there's an inflammatory response, it's more of M1, but if there's none, there's more of M2. And then if it is chronic, of course, there is a persistent M1 macrophage. And eventually, as it goes along, as it reduces, M2 will produce, and it could reduce pain, inflammation, and support tissue healing. So you can see here the area by which the M1 initially will go into play, and then eventually the M2. And so you can see here from point of injury, there will be release of inflammatory cells, and this could take several weeks. And this area here in the red is the one where M1 is mostly seen. But after that, between resolution and pervolution will take place, and M2 will be the one that is mostly present. And of course, as a result, there will be cellular proliferation, and then of course, ECM deposition, and then remodeling, wound contraction, and of course, repair would happen eventually. Now, there are pharmaceutical treatment for neuropathic pain. So the drugs are very familiar to us. So it could be classified to different classes. the tricyclic antidepressants. The more common is your amitriptyline. So this is considered the first line in neuropathic pain. Same holds true with the duloxetine and venlafaxine, which are the SNRIs. These are first line in neuropathic pain. And then, of course, the gabapentinoids, which are in the form of gabapentin and pregabalin. These are also first line in neuropathic pain. It acts either peripheral or central and peripheral if it is pregabalin. So you can see here the difference. If you want to include both central and peripheral, you choose pregabalin, but if you just want the peripheral, then you can just choose the gabapentin. Now, also, just to mention to you that tramadol is not the first line of treatment for neuropathic pain. It's actually the second line. And oxycodone and morphine are the third line. If all of this already fails, then you can consider doing that. And of course, drugs not recommended for neuropathic pain are all these drugs here. So in other words, if, for example, you're dealing with neuropathic pain and you tend to give these drugs here and it doesn't work, think about maybe you're dealing with neuropathic pain. So just by the non-effectivity of the drug that you're using, you can already maybe guess that you might be dealing with a neuropathic pain. So what are the regenerative interventions? So we have a lot. We have bone marrow stem cells, adipose stem cells, we had PRP, we had A2M. We have, of course, the Prolo, which is the lift of Prolo, making use of 5% dextrose. So here, the dextrose-based treatments could come in different concentrations. So for example, you're dealing with hypertonic hyperosmolar, which is 15 to 25%. This is the regular Prolo, which is used for ligaments and, of course, tendons, to tighten the ligaments and tendons, but not necessarily for the nerves. But this here is a little painful. The hypertonic hyperosmolar Prolo is painful in the beginning, but still it restores its mechanism, the integrity, the repair, then the pain will subside. But the perineural injection therapy, which makes use of 5% dextrose, are the ones which are very, very specific for nerves, especially for neuropathic pain. This is the one that reduces neuropathic pain, and the treatment should be adjacent to the peripheral nerves. You can use the skin references, or you could go to the area of the chronic constriction injuries, which we also describe as the CCIs or the Valley points. And this is the one that was taught to us by Dr. Liftoff to be very effective for nerves. Now, these are other description of this. This was just given as a lecture by Dr. Jazzy last week in the University of Wisconsin. So here you can see here that the glucose, especially for perineural injection therapy, should be buffered. It could be a buffered D5, buffered mannitol. It also includes some PRP and platelet lysate. Or if you use the regular Prolo, 15% extraarticular or 25% intraarticular dextrose. All of these are given in different modes. So what does it do? It stimulates regeneration and tighten lax ligaments. But for 5% dextrose, it restores trophic function to peptidergic C fibers and stimulate also regeneration and eliminate pain. So the prolotherapy should be given every 4 weeks, but the PIT or perineural injection therapy should be given weekly. So you would need 6 to 10 treatments for PIT, but for Prolo, you need 4 to 6, depending on the severity of patients. So NSAIDs is okay for perineural injection therapy, but not for prolotherapy. No NSAIDs before or after the treatment. So soreness will be usually felt 2 to 3 days if you're using the Prolo, the usual Prolo, but not with the PIT. The PIT, you will feel relief right away. So you will be receiving the PIT subcutaneously, or you can also use an ultrasound-guided nerve injections to relieve the pain. So this is a 5% dextrose, or you can use a cocktail. You can either mix it with B12, vitamin B12, or an ozone or hyaluronic acid, so depending on your practice. So no adverse effects have been reported, and there is an instant relief, but it may only last for up to 4 days. And that is why you need to complete at least 6 to 10 sessions if you are going to do the PIT. And of course, the pain will go down until completely the nerve is treated and the pain is gone. So how do you compare it? So usually, prepare it. So usually the 5% dextrose are acidic. So the pH is usually 4.5. So you can actually adjust it by mixing it with 1 cc of 8.4% sodium bicarbonate per 100 ml of D5 water, just to make it neutral. In other words, the pH should be at least at the range of 7.8. So when this is buffered, then the effect is much better as compared to if it's raw and injected right away. And the solution should not be kept for more than 24 hours. So when you use it and you don't anymore use it, so more than 24 hours, you have to discard the solution. Okay, so this was a research done by Dr. Reeves, and this is not yet released in the paper, but it's being still submitted for publication. But I just to show you here that the rate in the drop, especially in the first 10 minutes, okay, when you use the dextrose concentration curve, and of course you can see here that the glucose concentration drops very quickly, okay, minutes after injection. Okay, it's being utilized by the cells right away. So this is for the first 30 minutes, okay, and then of course up to about 270 minutes. You can see here the different effect, especially the trend of this. And of course, the primary findings illustrated here is that there is water movement, okay, out of the cell and into the cell. So a solution such as 5% dextrose will actually move from one area of higher concentration to an area of lower concentration. So at equilibrium, the hypotonic solution will actually cause the cells to swell. And of course, this swelling might also affect the status of the cell. But when we actually inject it and put the solution in the area where it is painful, then it will cause relief of the symptoms, and the osmolarity will go back to normal. And you can also see the change in the WOMAC scores over 12 months. You can see here the dextrose as compared to PIT, the PT as compared to saline. So you can see here the dextrose to be in a much better position here. Now, how about the role of stem cells in neuropathic pain? So the role of stem cells here is that it decreases the levels of pro-inflammatory cytokines. It promotes the polarization of macrophages to M2. Remember, M2 is anti-inflammatory. M1 is pro-inflammatory. And then, of course, it's neuroprotective. It promotes axonal myelin regeneration by acting on the GD and F. And of course, VEGF is the one that regulates nerve regeneration. Now, the TGF-beta-1 also attenuates glutamate-induced excitotoxic neuronal damage. So it also weakens and reverses central sensitization. It also inhibits glial cell activation. It inhibits microglia, which is the one that is responsible for releasing also the neuropeptides, but at the same time, releasing those pro-inflammatory cytokines. It also inhibits MAPK pathway. It reduces apoptosis and autophagy of spinal cord cells. So it all reverses this process, especially in the nerve that is injured. MSCs in the recovery process. So as you can see here, when there is an MSC administered, M1 is converted to M2. So there is a prevention of neuroinflammation in an area by which there is an inflammatory process. So the evidence shows that neurotropic factors improve neuronal survival in neuropathic pain. It also attenuates inflammation. It modulates the immune system, and it aids in the wound healing. So all of these are important in the healing process of a nerve. The mechanism also includes the polarization of macrophages to an anti-inflammatory. You've mentioned that from M1, it becomes M2. So as you can see here in this diagram, from M1 to M2, the moment you inject these stem cells, it has an anti-inflammatory role through MAPK pathway. So this is your MAPK pathway when these stem cells are injected into this area. And of course, it inhibits the expression of PARK1 and 2 in dorsal root ganglion that is induced by chronic constriction injuries. Now, the bone marrow stem cells here acts at the neuromuscular junction. And as you can see here, it acts on this receptor and it prevents also the conversion of microglia in a sense that it will disrupt the release of the pro-inflammatory cytokines and of course influence the non-release of the astrocytes right here. Other things that it does is inhibit opaque signal pathway. It also inhibits the expression of NMDAR and of course protect them from glutamate excitotoxicity. It activates intermediate inhibitory neurons, which leads to the release of gamma aminobutyric acid, which inhibit postsynaptic neurons through membrane hyperpolarization. This is a busy slide, but what it simply shows is that the stem cell modulation affects neuropathic pain pathway. How about the opioid therapy? Now, this is a very nice study because it says in the result that the stem cell therapy decreases opioid tolerance and hyperalgesia. So when you inject stem cell, even if you're taking opioid already, the tolerance is decreased and hyperalgesia is decreased, and the PTX for R expressing spinal cord microglia decreases, and thus the chronic neuropathic pain is also decreased. How about PRP? PRP here is found to actually influence neuropathic pain, and it shows improvement after 2 weeks of PRP injection, and it is effective than just PPP on nerve regeneration. So it releases neuropathic factors like NGF, BDNF, and IGF-1. Of all the good factors, the NGF is really the one that is painful, which is found in PRP. So that's why when you inject PRP, it's more painful than it's less painful initially, but eventually the pain would go away. So PRP and neuropathic pain, it has been shown to have an anti-inflammatory and analgesic properties. It has an optimal dosage, frequency of administration, appropriate stage for which PRP should be used have not been established yet. That's why further clinical studies has to be done yet in terms of knowing exactly which type of PRP has to be used. But comparing PRP with dextrose water, it's been found here that PRP is more effective than dextrose 5% for patients with mild to moderate carpal tunnel syndrome. So again, it shows the superiority of PRP than the 5% dextrose. Also, PRP is effective for mild to moderate CTS and is superior to traditional conservative treatments in terms of improving pain, function, and reducing swelling in the median nerve. And it also shows in the EMG that there is an improvement after PRP injection. Also, it has effect on the pro-inflammatory cytokines, and it balances the cytokines, which is actually in imbalance at this point with pain. The natural good factors that is present is also responsible for tissue regenerative and repair, and the good factors will, as I've said, not only modulate the cytokine imbalance, but also results in pain relief. And of course, the reestablishment of normal axon biophysical properties is also shown with elimination of hyperexcitability and elimination of neuropathic pain. It also inhibits inflammatory response by regulating PKM2-mediated glycolysis and STAT3-mediated astrocyte activation. So this is the mechanism by which PRP works, and it improves chronic inflammatory response. It also induces neuroregenerative by increasing NGF and S100B expression in 3 weeks. So this 100B is also present in astrocytes, and it is usually toxic or trophic, and it promotes recruitment of macrophages and migration of Schwann cells. And this is important in facilitating the repair of injured peripheral nerves. Now let's move on to another type of solution, in this case, A2M, something that I really love doing. I've been pioneering this work on nerves, And so there is a paucity of research on this treatment yet, but hopefully we can find some as we are doing research right now on A2M, we can give you whatever we found out in our study here. So as you can see here, it says that there are more studies needed for any of these PRP, MSCs, and includes A2M as well. Although there are research saying that A2M is good in discogenic back pain, especially those patients which are fibronectin aggregate complex positive or FAC positive in the disc. These are the ones that respond better as compared if you are not FAC positive, especially if you do an intradiscal A2M injection. The outcome measures were used for this study to compare the results of those patients treated and those who are not treated. Now, this is a relatively new study published 2024 of June, Intradiscal Autologous Biologics for the Treatment of Chronic Discogenic Back Pain. And they make use again of A2M and PRP and mesenchymal stem cells. And the results shows preliminary evidence for low back pain in terms of pain intensity, physical function, quality of life, and of course, patient satisfaction. So a very positive result for this study. Again, another study on A2M and neuropathic pain. It shows potential use as an adjunctive treatment option for chronic pelvic pain. This is the pudendal nerve in the Alcax canal. So they hydrodissected this area and they see the relief of patients with chronic pelvic pain. Another study for neurogenic thoracic outlet syndrome, where they use A2M as well. The conclusion is that it's a relatively safe, and it also is a treatment that is very important, especially for thoracic outlet syndrome, as an alternative to steroids and repeat surgical decompression. So of course, we know the side effects of steroids. And so if you don't like the treatment, then it's good to consider A2M to be your treatment of choice. Now, we also published this study on A2M for neuropathic pain. This is a neuroma pain, the stump of Belloni patient. This is actually one of my first patients I treated with A2M. He was suffering from severe pain, especially on weight bearing, using a Belloni prosthesis. I started him with dextrose 5% dextrose water. It didn't work. Then I moved on to PRP. It still didn't work. And the father was talking to me and said, "Okay, don't you have any other treatment?" I was hesitant in the beginning, but eventually he convinced me, okay, probably why should you start doing what you still have there? And so we decided to do an A2M. And 2 days after the treatment, the pain was gone. So we finished a total of 3 treatments weekly. And until today, the patient is pain-free. And another research also here, 2013, the effectiveness of A2M in the osteoarthritis of the knee. So they actually use A2M intraarticularly to be injected into the joints with knee pain. And as we know, A2M is not only good for pain relief, but also it actually inhibits cartilage degeneration. So this is really good for severe knee joints. And of course, the study shows that there's still no difference at this point as compared with other treatments. Now, this is also the study that we published in 2022. We explained how the process of A2M is done and how it suppresses neuroinflammation by actually inhibiting the pro-inflammatory cytokines, as you can see here, interleukin-1, interleukin-6, and TNF-alpha. So this is the exact area where A2M works, and we explained it here in this study. And of course, it has a better response than with nociceptive pain. So this is the preparation. Thanks to Apex for showing me this slide of how the A2M works. So there's a filter in the middle. So as a result of that filter, we put the PPP inside the filter, and then we push back and forth, like this one here. And then as a result, we come up with a small portion of A2M in this tube right here. Then I put on a laser. The laser will actually enhance the growth factor. And then after 20 minutes of exposing with the laser, then we inject it to the patients. And usually for nerve injury, nerve entrapment, and of course, compression, chronic constriction injuries. So this is an example of a 47-year-old patient complaining of pain in the left gluteal area, referred to the left leg. So we scanned the sciatic nerve and it was swollen. So what I did was, let me see if this slide will run. So, oh, seems to be not running at all. So anyway, so I'm sorry for that. So we targeted the sciatic nerve in this area. And then, of course, we use A2M in these patients. Then another one is the C6 nerve root injection using A2M. Hopefully this runs. Oh, this doesn't run again. This is a 44-year-old patient with a 25-year history of recurrent chronic pain. It has a multiple level disc bulge from C4 to C6. And initially, he was taking medications and physical therapy with no long-term relief. And eventually, we decided to do A2M. So it has been maybe 2 to 3 years since we treated this patient. And up to now, the patient is pain-free. So another example is an ulnar nerve. Yeah, this is 2022. This is a 61-year-old patient with recurrent numbness of the left upper extremity with weakness of the fourth and fifth digits. So we scanned the ulnar nerve and it is swollen. And so, oh, it's not working again. So I'm sorry for that. But yes, after the treatment, the patient was pain-free and the numbness is completely gone. So these are just examples of those treatment that we were doing. So again, in summary, it is important that we actually establish the diagnosis of complex and challenging process of diagnosing neuropathic pain. I know it's a very tedious process, but still always consider pain patients who doesn't respond with usual medication to be probably a candidate for neuropathic diagnosis. And then started with either prolotherapy, neural prolotherapy with 5% dextrose. If it doesn't work, then start using your PRP. If it doesn't work, then you can always use your A2M. So we're not saying here that you have to try all these processes first, but what we're saying here is that these are examples of cases that we can try on those treatments on a more stratified manner and avoid surgical intervention if possible. So a lot of patients would not want that, but just in case it's really needed, then we can always refer to our orthopedic friends the need for surgical intervention. So even as we are into this treatment already, there's a lot of research to be done, and there's still a lot of other things to be understood in the process of understanding these type of problems. And we actually encourage everyone that if you have the opportunity to do research, then do research for neuropathic pain intervention. So thank you very much, and God bless everyone.